2, 1. Please start. We are live.
Very good evening, one and all distinguished delegates and our eminent speaker, Dr. Vivek Mathur, sir. And I am Satish Rama Joshilkar from Zydus Medica, honored to welcome you all to the scientific platform called CLEARTalk. A little delay because of technical issue, but speaking about CLEARTalk, brief introduction of CLEARTalk. CLEARTalk is one more initiative of Zydus for Unite Against Dyslipidemia. As you are aware that in India, 1.4 crore of Indian population is suffering from uncontrolled LDL cholesterol. And the recent development in the field of management of LDL cholesterol has been quite phenomenal. In ACC 2023, there was a clear outcomes trial which was published on bempedoic acid, and this is the latest happening. Without wasting, we would like to hear from Dr. Vivek Mathur, sir. To give a brief introduction of sirs, I would like to uh, say that Dr. Sir is a senior consultant interventional cardiologist at Mittal Hospital, Ajmer. Sir has fellowship of Society of Cardiovascular Angiography and Intervention, USA. He's a fellow of European Society of Cardiology. He's an expert, heart failure expert, ESC, HFA, life certification in Vienna, and he has huge experience, many publications to his credit. So we are having the best of the speaker for today's. I would like to hand over this session to Dr. Vivek Mathur. Thank you, sir.
Thanks for the kind introduction and very good evening. And I welcome all the delegates and those who are soon going to join us on this clear talk. And we'll be talking about the current management of dyslipidemia, the focus on the drug bempedoic acid. So, bempedoic acid is, we're going to discuss through the lenses of the clear outcome trial. This is a trial which was published and which actually give us the evidence about bempedoic acid as a dyslipidemic agent. Now, with the background, what happens? Why do we blame LDL? Because it's an oxidized molecule which has a very key role in the development of plaque in the arteries and also responsible for plaque rupture and also the inflammation inside the plaque. And that's why we want to calculate this in our blood and want to keep the levels low. Now, how much low should be there, and what is the clinical outcome and clinical benefit with control of LDL? So this has been shown in the trials that if you're going to reduce the LDL and the percentage, if the patient remains, if you're able to control the LDL for 1 year, 2 years, 3 years, 6 years, does it translate into clinical benefit? So there is the evidence comes from the various trials that if you have controlled cholesterol, the LDL cholesterol for at least a year, this is 11% reduction in the risk of cardiovascular event. And this continues to rise. If you are able to control it for more than 5 years, the risk reduction is up to the tune of 36%. And also, the risk of non-fatal MI, cardiovascular death and stroke also over a period of 5 years also go down. So LDL molecules, if we have a declining LDL concentration, the amount of risk with CVD, diabetes also tend to go down. So this is an important point that both diabetics, no diabetics also get benefit by reducing the LDL cholesterol, but more so with the patients who have already established cardiovascular disease and diabetes. So if you are able to control the amount of LDL molecule in the blood, this translates into lesser new non-fatal MI, cardiovascular death, and stroke. So such is an important part and the target of our control or therapeutic intervention is the LDL molecule. So management of dyslipidemia is high on priority and the statins are the first line therapy. Now we all know that we have the various, apart from the dietary management and the lifestyle modifications which are of paramount importance, we want to control the dyslipidemia with the primarily with the statins, along with the, as we have talked, the lifestyle management and dietary therapy. Now, Besides statins, what are the other options which are available to us in addition to statin? And sometimes when the patients are intolerant to statin, what are the other agents that we can go? So, what are the various concerns that we have? Do all statin users achieve LDL goals as per the guideline? If you give the patients an LDL lowering agent, how much benefit does it grow, and how much it is able to control the LDL, and what dose which is responsible for that decline? And is that the dose same for all the individuals, or individuals have variability? Secondly is how to achieve LDL target after maximally tolerated dose of statin. If the patient is not able to control have the LDL levels on maximally tolerated dose of statins, what are the options that we have? Now, management of dyslipidemia again requires what are the distinct. So we see that the LDL so lower is the better is it has come from the JAMA 2016 that we know that the relative risk reduction per 38 approximately 48% reduction in LDL translates into 38.7 milligram deciliter translates into 23% relative risk reduction in the patient's relative risk of major cardiovascular event. Now, this is the various interventions that have been correlated here. We have PSK9 inhibitors. 2 trials are there. Ileal bypass is there. 25 statin trials are there. 25 trials. 4 trials for dietary intervention. Niacin 3 trials and fibrate 9 trials. Now, weighted between group difference in achieved LDL-C. Now, what do we get here is the relative risk reduction in the tune of about 50% for PCSK, ileal bypass close to about 30 to in between 40. Statin close to 20 as we have come 23, 20. Yeah. Bile acid sequestrants also. Dietary results are also close to 18 to 20%, but ezetimibe as such in the tune of less than 10%. This is the various trial data that we have here. So comparison of LDL-C target 2016 versus 2019. Now we have different category of patients, low risk, moderate, high risk, very high risk. So the targets have been further lowered. For low risk category, we want to keep the targets below 115. Patient who is moderate risk want to keep the LDL below 100, high risk 70, and very high risk 55. Now, as the risk increases, there is a need to reduce the LDL cholesterol. Now, based on the revised ESC 2019 guidelines, how many patients do have controlled this thing? Now, European-wide cross-sectional observation study of lipid modifying therapy used in secondary and primary care, the Da Vinci study. This is a cross-sectional observational study of patients prescribed lipid-lowering drugs for primary and secondary prevention. 18 countries, 5,000 patients, primarily 3,000 patients, secondary patient 2,000 patients to evaluate the effect of the guideline management on LDL-C achievement. So the Da Vinci statin usage in all patients was there for primary and secondary prevention. The overall outcome was this is the graph is showing proportion of patient lipid lowering therapy. Now this is the various charting. So overall 54%. Now how many patients were able to control on the current guidelines? About 33 patients who were on statin. All statin patients were able to, out of them, all the statin patients, 33% were able to achieve the goal. Now, those who were on low intensity monotherapy, 28% were able to control. And those who are on moderate intensity, 37%, high intensity, 30%. So you can see high intensity statin monotherapy, the patients who were able to control their LDL cholesterol was 30%. Whereas ezetimibe combination a little higher, 37% were able to control the cholesterol. But PCSK9 inhibitor combination along with statin were able to control about 57% were able to control their, achieve their goal. And other lowering therapy, only 14% were able to control it. So you can see that as per the revised guideline, about 27% of eligible patients are receiving high intensity statin. So high intensity statins, 30% achieve only the goals with high intensity statin. There is an unmet need for the rest of the patients for the patients to control their LDL goal. Okay, so this is the chart that we have. Now, what is the statin use in very high risk patients? About very high risk patient guidelines, very high risk patient, 37.5% eligible patients are receiving the high intensity statin. Only close to 40% of the eligible patients are on high intensity statin, and 22% of the patients with high, achieve the lipid goal with high intensity statin. So, any patient. So, there are two unmet needs. One, very high risk patients, only 40% on high intensity statins, about 60% still should be on high intensity statin. And out of these high intensity statin patients, only 22% are able to achieve their goal. So again, there is a need for agents to control this unmet need. Now, what is the management of patient receiving bempedoic acid therapy? Now, this drug is a half-life of about 21 hours. 70% is through kidney excretion and 5% is infusion and excretion unchanged through the kidney. So, what are the benefits? Renal impairment, no dosage adjustment is ready, not studied in the end, so not eligible for ESRD patient. Hepatic patient, no dosage is required, adjustment, and it is again not to be given in severe hepatic impairment because we don't have a data. All patients, what do you need to monitor? All serum uric acid when clinically indicated. Uric acid you have to see. Increased vigilance for the hyperuricemia and gout should be there. Patient over 60 years of age taking corticosteroids or fluoroquinolones with renal failure and history of tendon rupture. So you should be very careful about that. Want of potential for tendon rupture and advise patients to rest at first sign of tendonitis or tendon rupture. So this is very important that we have to see the tendonitis in these patients. Now, patients who are discontinued to, if they are patient who was on steroids, fluoroquinolones, renal failure, and history of tendon rupture. Four important group of patients who are more than 60 years having steroids, fluoroquinolones, either of them, renal failure, or a history of tendon rupture. So if their tendon rupture, discontinue. If the patient is considered, if there is joint pain, swelling, or joint inflammation is there. If they are taking simvastatin more than 20 milligram or pravastatin 40 milligram, avoid concomitant use with bempedoic acid. So high dose simvastatin and pravastatin along with them, not to use the bempedoic acid, and consider lowering dose or switching to statin. Difference. Pregnancy, discontinue of bempedoic acid unless benefits of therapy outweigh the risk. Breastfeeding is not recommended during the bempedoic acid treatment. Now, what is the clear outcome trials? This is the late ACC 2023 cholesterol lowering via bempedoic acid and ACL inhibitor regime. So this is an NEGM article on and cardiovascular in the statin intolerant patient. Now, what is the clear outcomes? It's a global CVOT study with bempedoic acid in statin intolerant patients with LDL-C. Now, primary and secondary patient prevention patients with elevated LDL-C and statin intolerance. Statin intolerant patients, screening was done, visit first 3 week, 4-week run-in period treatment with single blind placebo, then visit after day 1. Bempedoic is 120 milligram versus placebo. Study completion was there after the 1620 primary 4 component MACE, at least 810, 810, 3 component. This thing. Primary endpoint was placebo versus bempedoic. CV death, non-fatal MI, non-fatal stroke, coronary revascularization, all these. About 13,000, close to 14,000 patients, and approximately nearly more than 3 years follow-up. Now, this is the demographic data. The average age was 65. BMI was a little, these patients were there. LDL cholesterol was 139. HSCRP was a little higher at 2.3. ESR was more than 90 in most of the patients. Cardiovascular category, primary prevention, equally distributed, 2,000 patients, 100 patients for primary. In the placebo arm, 2,000 patients. Secondary prevention, more patients, about 5,000 patients. CAD patients, 3,000. PAD patients. Cerebrovascular atherosclerotic disease, glycemic state, about close to 33,000 patients, and 1,000 uncontrolled diabetic patients. Statin use was close to 22.9%. Ezetimibe use was 11%. Now, the relative risk reduction in the 4-point MACE was 13% with bempedoic acid, 3-point MACE 15%, and above fatal to non-fatal by 23%, coronary atherosclerization by 19%. So, 4-component MACE as compared to placebo, it was beneficial. 3-component MACE, again, there is a divergence of the curve. Fatal non-fatal MI were less. Coronary revascularization were again less as compared to placebo. So background. So statin intolerance, bempedoic acid, CV outcomes were not assessed as such, but statin tolerance is in 15% of the treated patients, prevent patients from achieving LDL-C levels and cardiovascular benefits. So if bempedoic acid is a ATP cyclase lyase inhibitor, and bempedoic acid approved for lowering LDL-C now. So primary and key secondary endpoints are 4-point MACE is non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death. All these were reduced with bempedoic acid. And hierarchical testing of key secondary endpoints like 3-component MACE, fatal non-fatal MI, coronary revascularization, strokes, cardiovascular death, and all-cause mortality. They all go down with the patients with bempedoic acid. Now, effect of trial regimes on cardiovascular. Among statin intolerant patients, treatment with bempedoic acid was associated with lower risk of 4-component MACE, 3-component MACE, MI, and coronary revascularization. What is the difference? 4-component MACE goes down by 13%, 15% MI, non-fatal MI, 23%, and about 19% reduction in the coronary revascularization. So LDL-C and HSCRP reduction. Now, these patients, about 21% in LDL-C reduction was seen in the patient over a period of time. So first, initially, up to the 3 months, there is a rapid form, then it tends to stabilize. And after a few years, about nearly more than 2 years, they also continue to go down. And HSCRP levels also go down to about 19% with the bempedoic acid. Now, clear outcomes trial safety analysis is serious adverse events are comparable to placebo, 25%. Adverse events leading to discontinuation of trial, about 10.8%. Myalgia, 5.6%. Discontinuation due to myalgia, 1.8%. NODM patients with diabetes at the baseline, 16. Renal impairment, 11.5%. Changes from the baseline, 0.05. Creatinine hyperuricemia, 10.9%. Gout, 3.1%. Change from baseline uric acid, close to 0.76 after 6 months of therapy. So, very little rise in the So, to conclude the clear outcome study, bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction of these 4 events in patients with and who are at high risk of CVD with documented statin intolerance and elevated LDLs. So, to conclude, bempedoic acid an effective alternative for statin intolerant patients, and also it is well tolerated. Bempedoic is well tolerated in mixed population of primary and secondary prevention patients unable to or unwilling to take statin. LDL-C and HSCRP reduction. Bempedoic acid lowered LDL-C by 21.7%, HSCRP by 22.2%. Small increase in the incidence of gout and polylithiasis. Primary and secondary endpoints. The primary endpoints, 4-point MACE was reduced by 13, 3-component MACE by 15%. Myocardial infarction by 23% and coronary revascularization by 19%. Bempedoic acid has effective approach to reduce major cardiovascular events in statin intolerant patients. Thank you for your kind attention, and here we conclude my talk. And if at all there are any questions that we are able to.
Thank you so much, sir. Thank you, such a elaborative presentation and crisp presentation. on Clear Outcomes trial on Bemdac acid. There are few questions from the audience we'd like to ask one by one. Sir, there is one question which has been raised as you were talking about 2019 guidelines on LDL cholesterol management. So, how far one can go to LDL cholesterol? How low one can go for LDL cholesterol? That was the question with bempedoic acid and bempedoic acid acetamib combination.
So, since we have seen that there is a modest reduction of LDL cholesterol with bempedoic acid, so most of the time, if the patient, we have to see how much cholesterol, LDL cholesterol does go down. Initial aim is to bring down the cholesterol levels by about 50% in the patients from their baseline. This is the first idea. And if you are able to control or bring down that, but it depends how much low you want to go, depends on the class of patient. If they are high risk patient, the initial aim is to be able to get down, to bring down the LDL cholesterol to about less than 55. Now, bempedoic acid, whether it is able to control to bring the target values, I'm not sure. So it is more with the bempedoic acid plus statin combination that helps control the bring down the LDL cholesterol. But yes, control giving the bempedoic acid in statin intolerant patient does bring down the LDL cholesterol by about 23%, so something like that. So alone bempedoic acid is able to control the target values is not yet clear, but yes, it does translate into clinical benefits.
Thank you, sir. Thank you so much. The next question from the audience is, I have many patients with type 2 diabetes and hypertension. So what LDL target should I keep for these patients?
So again, this is very important to understand the patient, what kind of patient that we are dealing with. If your patient is a diabetic and hypertensive, so in diabetics, your initial aim is to bring down the cholesterol levels, LDL cholesterol to less than 100. Now, if the patient is also a polyvascular disease, for example, the patient has already, the diabetic patient with multivessel disease or peripheral arterial disease or very high risk patient, then you should bring down the LDL cholesterol to less than 55 milligram deciliter. Uh, this should be the aim. So the lower the better. All the diabetic patients should aim for LDL cholesterol of about 70 milligram percent. But for the very high risk patient, it is 55 or even less. And the ability of again patients who are able to control the LDL cholesterol comes down by about 22% after a therapy of close to 3 months with bempedoic acid. So you can expect a fall of about 20% or close to 20% with the initiation of bempedoic acid. So if your patient was already on LDL cholesterol lowering drug, statin for example, you can expect further lowering of about 20% by additional bempedoic acid. And for HSCRP, similarly, about the amount of HSCRP that could be addressed, a drop in HSCRP is close to again the same 22%, close to 22 to 90, 20 to 22% decrease in the HSCRP, which is an inflammatory burden from the initial baseline value. Next.
Thank you, sir. Thank you so much. Next question is related to LDL cholesterol. Again, if patient is having elevated LDL cholesterol with moderate statin dose, then what should I do? Either whether should I increase the dose of statin or directly add bempedoic acid or bempedoic acid plus ezetimibe?
So, as per the guidelines, first you should exhaust the if the patient is able to tolerate the maximally tolerated dose of statin, and still you are not able to control you bring down the LDL cholesterol levels to the target values, then you should add the bempedoic acid. But in the real world patient, if the patient is statin intolerant, or if you have any other concern, then the patient can be added on ezetimibe or bempedoic acid in such patients, so that we can address the goal. So important is to bring down the LDL cholesterol. So
Yes.
as we have seen that the pleiotropic effects of statins are there, so first line you should consider increasing the dose of statin. Hmm.
Thank you, sir.
Okay.
Thank you, sir. Yeah. And this is the last question from the audience. Is what in routine practice, how much bempedoic acid is safe to use for longer duration? Is it benefited in diabetes mellitus patients?
So the trial is for 4 years, 40 months or something like that. So approximately 36 months, the clear cut data is available. At least for 3 years you can give, but you have to be careful for few points. For example, more than 60 years, renal artery, renal failure patients, the patients who are on drugs like fluoroquinolones, and fourthly, any patient who have tendinitis, joint pains, joint inflammation, or this thing. These are the few things that you need to monitor. You should be monitoring the uric acid or the renal profile of the patient because it is excreted and from the metabolized to kidney. So at least 3 years you can give. And for the patient, actually the trial, the clear outcome trial, we have equal number of patients. For example, for primary and secondary prevention, you had a mixed bag of diabetic and non-diabetic patients. So, as it has already been tested in the trials in the diabetic patients, it is safe to use in the diabetic patients. And as we know of today, it is indicated for statin intolerant patient and as an add-on for the patient who are on maximally tolerated statin dose and who still not able to get to basically the LDL cholesterol goals, and it is a molecule to look for.
So one more question popped up. That the question is, uh, uh, is it appropriate to keep LDL cholesterol below 40 milligram per deciliter as per guideline recommendation? Can it lead to any neurological complications?
So as of now we are concerned about since we have the data from the previous trials that if you are able to bring the cholesterol levels to less than 55 milligram. But again, who are the patients whom we want to consider bringing down the cholesterol levels to less than 40 or less than 55? These are the already very high risk patients, and in which the various research and evidences have shown that keeping their cholesterol levels, and especially the LDL cholesterol levels, to less than 55 is translating into a clinical benefit, that is the MI, revascularization, death, and all these are less. So our aim is to get the cholesterol levels below 50. Now the second point is how much any other side effects are there. One is the drug side effects can be there on very high doses of the drug that we are using to achieve this aim. And secondly, neurologically, because high dose statins have been found to be clinically associated with dementia and development of diabetes also. Now, a few things that you should be looking for, again, the neurological manifestations of memory, dementia. Although these are very less in proportion, but still, on very elderly patients on high dose statin, definitely you should look for the neurological manifestations of the long term use of the statins. And as well as the myalgia and all those things which happen with high dose statins.
Thank you, sir. Thank you so much. This was a wonderful interaction indeed. And I'm very honored to have you on this clear talk and clearing all our doubts on bempedoic acid. And before we conclude this meeting, would you like to have any closing remarks on today's session?
So, my concluding remark will be, so since we are dealing with dyslipidemia, one, we have to identify our patient first. What kind of patient that we are dealing with? Classify them according to their risk. Then identify their LDL goals need. And then you should see what agents and what dose of that agent you will going to see with monitoring of the different side effects. And if you're able to do with the contemporary management, then we have other, if there is still unmet need, then we have good molecules like ezetimibe, bempedoic acid, now evolocumab, the PCSK9 inhibitor. All these things are on the are there available on the shelf to bring the LDL cholesterol well within the limits.
Thank you, sir. On behalf of Zydus Life Sciences, I would like to extend our sincere thanks to you for your comprehensive session. We are sure that our delegates would have definitely got enlightenment regarding the usage of bempedoic acid, as you covered all the possible aspects of your session. And at the same time, we would like to thank you all the delegates for their presence and patient hearing. Thank you all once again, and have a great evening. And thank you so much, sir. We are very obliged to have you on here on this evening. Thank you, sir.
Thank
Good
you.
night.